let me come down to you, pharmacist Fagbinro, talking about how best, in its simplest context now, how well can you help us break it down? Talking about the definition when we say drug interaction, what do we mean by drug interaction?
Thank you. Drug interaction simply means altered drug response or change in the effect of drug that is produced as a result of a concomitant administration or intake of a drug with another drug or other substances like alcohol, herbal preparation, thereby now producing change in the patient response to the drug.
So at the point where a patient is not using the drugs properly or combining the drugs with other, destructive items or liquid, it could be alcohol, like you said,
Yes.
it becomes wrong at
Yes,
that point.
because it's a risk for having drug interaction.
It's a risk.
Concomitant administration of the drug with other drugs or other substances like food,
Mm.
chemical, herbal preparation, alcohol can lead to drug interaction.
That is to say, let's come down home now before we even go ahead with other questions. Some people will tell you that when I use my medications, that is the English medications, like we call it, I can
Drug.
still mix it with the herbal so as to balance it in and so that I'll recover quickly. Are you saying that that is actually not the right thing to do?
Actually, yes, it's not the right thing because there can be interaction between that drug that been taken with another substance like alcohol, which can be the effect can be fatal or dangerous.
Hmm.
So, and drug interaction is a drug therapy problem that
Hmm.
have to be identified and resolved by pharmacists or physician for because the therapeutic effect that we are expecting from drug will not be there. For example, if drug A is being co-administered with drug B
Hmm.
and drug B is affecting the work of drug A, that
Hmm.
drug B is known as a persistent drug. While
Okay.
drug A that has been altered, as in the response is being altered or the effect is being altered, is known as object drug. So
Hmm.
the two drugs now interacting with each other will elicit either increase or decrease pharmacological response, which might be unusual.
Hmm.
So and another one is it can cause rapid or slower action,
Hmm.
pharmacological action that we're supposed to see from the drug, or at times it can even cause adverse effects.
We will still get to that point where we talk about the dangers that are involved. It's a process, so we take it step by step. If you're joining us, it is drug interaction today on the issues, and we're looking at some of these effects. And you've heard the voice of one of our pharmacists well seated in the studio here. I want to ask, talking about self medication now, even before we go to the next question, this is one question a lot of people need to learn from when we talk about self medication. Some people will naturally just tell you, when I have headache, this is the drug I will take. And I always take them before it works for me, without any prescription from a pharmacist such as yourself, without any prescription from a doctor. What can you say to this?
Thank you. We have something that is called responsible self-medication.
Hmm.
Responsible self-medication is when one is taking an OTC. OTC means over the counter drug. If
Hmm.
one is having headache, if you take paracetamol for example, eh, after 3 days if the headache doesn't resolve, you have to go to hospital.
Hmm.
So responsible self-medication, if a child or an adult is vomiting for example,
Hmm.
is losing the electrolytes and water from system, which
Hmm.
which can lead to dehydration. So the patient need a responsible self-medication, like just taking what's it called oral radiation therapy,
Hmm.
just to radiate. But the major thing is that after first aid treatment of that radiation with maybe ORS,
Hmm.
popularly called ORS, after that one the patient has to visit hospital.
Hmm.
So responsible self medication is okay with over the counter drug known as OTC.
Hmm.
But mostly all precision drugs, because we are going to talk on drug interaction today, most precision drugs we have to visit a physician and
Hmm.
pass through pharmacist when they establish hospital.
All right. Thank you for that clarification. We're gradually getting there, and of course, it's going to get better. Drug interaction today is the focus on the issues. Now, I would like us to talk about some of the contributing risk factors You know, when you talk about drug-drug interaction, what are some of these contributing risk factors for drug interaction? Because definitely you would agree that this is something we should also talk about.
Yes. Thank you. Definitely, there are some processes that must be avoided
Mm.
in order not to have a drug interaction. Because I've already informed you that drug interaction is a drug therapy problem
Mm.
that must be identified and resolved in order to get good result from the drug we are taking.
Mm.
Now, if a patient visits hospital, the primary goal of coming down to hospital is to get better, and the
Yes.
primary aim of the healthcare workers is for the patient to be well too.
Mhm.
So all these goals will not be achieved because after physician consultation, consultation with physician will ask some questions. These questions that the physicians are asking is known as subjective findings.
Mm.
It is from these subjective findings that the physician will infer from all the question, because subjective findings is asking the patient about what drugs have you been taking, how long have you been taking it, are you taking drug, the name is past and present medication history. That's subjective
Past and present medication
medication
history.
history.
Mm.
That's is example of that subjective finding that the physician is going to is
Mm.
going to ask the patient. Now, in the process of asking patient that what drugs are you on, are you are you taking herbal preparation,
Mm.
are you on alcohol, if you normally take alcohol, are you a smoker? All
Mm.
these things, what doctor wants to infer from these questions is to get to know the risk factor
Mm.
that from the patient.
Mm.
So number one, if the patient now responds, doctor cannot just write a drug for patient. From this investigation, the doctor will know the assessment, that's in
Mhm.
the ailment, the diagnosis of the patient, that
Mm.
this patient is suffering from this disease. Now, physician will now draw plan of action. The plan
Okay.
of action, the major aspect of plan of action is drug. That's
Mm.
why efficacious drug has to be prescribed, and the drug must not have problem. The part of the problem is drug interaction. Now, for example, if a patient gets hospital and physician asks some question, that what drugs are you on, are you on other medications, are you on this, are you on that, and patient now listed out the name of the drug. I'm on nifedipine, which is an antihypertensive drug. I'm on metformin, which is anti-diabetes. I'm also taking salbutamol.
Mm.
I'm also taking salbutamol, which
Mm.
is for what's called asthma. And
Okay.
the patient also say, I'm also taking omeprazole, which is for ulcer. From all the listed drugs, the physician will have inferred from it that this is a comorbid patient,
Mm.
and the patient is suffering from so many ailments, so many diseases, and that comorbidity is a risk factor. That's number one.
Mm.
Now, anybody having comorbidity will definitely be given plenty medication,
Mm.
and that one is called the multiple therapeutic regimen, which we refer to as polypharmacy.
Mm.
Taking, so if medication is more than 4 for a patient,
Mm.
that means the person has a multiple, what's it called, a risk factor of a multiple therapy,
Okay.
which is known as polypharmacy.
Mm.
Now, if a patient that is sitting down in front of the physician, that physician is asking, making some investigation,
Mm.
is another patient, that's another risk factor.
Mm.
Because as one is getting old, all the organs and the systems in the body will be having diminishing work, diminishing work.
Mm.
Especially all the liver, kidney, and some others like that. So old age is another risk factor.
Mm.
So if a patient now said, if I come to hospital, I always attend 3 or 4 clinic. The patient is attending cardiology clinic, is attending endocrinology clinic, and also attending
Mm.
mental health clinic.
Mm.
That shows that the person will have multiple prescribers. Multiple
Mm.
prescribers, that is going to have prescription from cardiology clinic, is going to have
Different
prescription.
medical practitioners.
Yes.
Mm.
So that's another risk factor, having multiple prescribers.
Mm.
So now, another risk factor for a patient, if a patient is critically ill
Okay.
or is having critical conditions,
Mm.
the is a risk factor. The reason why it's a risk factor is that the organs that are supposed to work to counteract effect of drug interaction are the liver, because the liver, for example, is the major metabolism take place in the liver. And
Mm.
if the liver critically or chronic patient is having issue with kidney, liver, that means there might be nothing to resolve what's it called, drug interaction.
Mm.
The way body normally resolve drug interaction at times is through homeostasis. Homeostasis, that to maintain balance in all balance in the system, body system.
Mm.
So
Thank you very much for that clarification. Before I come down to pharmacist Akazi, I still want to stay with you, pharmacist Fagbenro.
okay, sir.
Now, this question I want to ask is something that is oftenly said when it has to do with drugs. At a point where they say this person is no longer active to a particular drug, maybe because the person has overused the drugs. So you hear that I don't use that drug anymore. Jare. I've used it, use it, use it, use it. It's no longer working for. At that point, what can you say about that? What exactly is wrong in that kind of situation?
Okay, thank you.
Yes, please.
At times, if there's something called resistance,
Mm.
if a patient is used to taking antibiotics, maybe personal antibiotics every time, a time will come that the organism too will develop resistance to the antibiotics.
Mm.
The antibiotics will not work on that organism again. So if the patient take the maybe or some antibiotics, the antibiotics will not work again. That means the person has developed what? Resistance.
Mm.
So, and at times it might be a patient factor, because non-compliance is another risk factor for drug interaction.
Non-compliance.
Yes.
Very well.
If a patient get to pharmacy, for example, after leaving the physician, the patient get to pharmacists will do education and counseling properly on the spacing of the drug, that two drugs. Maybe the patient is co-administering three drugs together. Pharmacist will now explain, take this drug before for example, antacid. Antacid has a complex ion inside it and interacts with most drug. So that's why if you get to a pharmacy and pharmacy is telling you that take this drug between meal means that antacid you must not take it with drug, and you must not take it with food, because of possible interaction. So if a patient now get home, he doesn't comply and now take the drug, maybe immediately after, the parent say, I'm not this drug is not working. It's not that the drug is not working. The patient is non-compliance to
So that, yeah.
instruction.
All right. Thank you very much. We would, of course, accommodate questions. We would, of course, accommodate contributions today on the issues while we talk about drug interaction on IKD 106.1 FM. The conversation has started, and of course, it would get better. I would like to come down to pharmacist Akezi now. There is another case scenario. I like to look at every angles to conversations. There are times you go to a pharmacist, and then maybe the drug that was prescribed by a doctor or a medical practitioner is maybe drug A. And then you get to the pharmacist tells you that, okay, this particular drug A is not available, but you can take drug B, of which the medical practitioner actually prescribed drug A. In that case, as a pharmacist, what can you say to that? Is it okay to go by drug B because the pharmacist said so, or you still insist? We are making people understand these things because they are listening to you, or you insist and say, no, I want drug A, or you go somewhere else. What do you have to say to that?
Okay, thank you for that question. Usually, in these type of situations, the doctors probably write a brand name, say Augmentin. Now,
No, let's not do advertisement for that.
no, okay, no
Yes,
problem.
yes.
Say
Amoxiclav.
Amoxiclav.
Oh, okay.
Now, there are many companies that produce the same thing, amoxicillin clavulanic acid.
Hmm.
But then a doctor wants a brand. Now, take for instance, that brand is scarce or that brand is expensive, and the pharmacist has seen that this patient cannot afford that brand. So they offer other companies' products. The same active ingredient is inside, amoxicillin clavulanic acid, but just of a different company.
Mm.
I'm just using that.
Yes.
Diclofenac, paracetamol, celecoxib, omeprazole, they are all this. They are all. There are so many of them, but
Mm.
from different companies. The same active ingredient is in it, and they will all do the same thing.
So it is okay.
Therapeutic
Yes.
alternative.
Okay, as an alternative. Because in some cases, some people will decline and say, no, if it is not drug A that the doctor said I should buy, I am not buying. So I just needed that clarification.
So far, it's the same active ingredient that is in it. It's good to go.
So the patient is supposed to, first of all, confirm if the active ingredients are
It's
same
the same.
with
Yes.
the one that was prescribed.
Yes.
We will take in your calls. We see the phone lines are buzzing. But then let's come down to another very important question, pharmacist. What are the classification of drug interactions? Let's also talk about that, or what we call mechanism of action.
Okay, drug interactions occur basically through two major mechanisms.
Okay.
That's pharmacodynamic and pharmacokinetic.
Mm.
For the pharmacodynamic ones, the effect of one drug is changed due to the presence of another at the site of action, and then there are about two: antagonism and synergism. In the antagonism, there are drugs with opposing actions.
Okay.
For example, let us take salbutamol. Salbutamol helps in asthma by relaxing the smooth muscles of the bronchioles.
Mm.
Now, on the other hand, if that same patient is prescribed propranolol, propranolol does the opposite. It causes constriction of the smooth muscles.
Mm.
So, in this situation, we need to escalate to the physician and draw
Okay.
his attention to it.
Mm.
Now, this same antagonism can work in a positive way in case of drug overdose.
Okay.
Now, let's take for example pentazocine. Pentazocine is an opioid. Now, in case of pentazocine toxicity, naloxone is used to take care of that.
Mm.
And that is because naloxone antagonizes the effect of pentazocine.
Mm.
Now, let's go to the synergism aspect.
Okay.
We've spoken about antagonism.
Oh yes, which is the first?
So, synergism, there are two drugs with similar pharmacological effects.
Mm.
Once again, this can go in two ways, positive and negative. For the positive ones, we have aspirin and caffeine. These are two pain relieving medications.
Mm.
When mixed together, when combined together, the pain relieving effect is stronger than when you use aspirin alone or when you use only caffeine.
Okay.
Now, the negative side, if we have, say, aspirin, a pain reliever, and then warfarin. Warfarin is an anticoagulant. What it does basically is to thin the blood, prevent clotting of blood.
Mm.
Aspirin at a high dose too is an antiplatelet. It does the same thing. So when that is combined together, the patient can run the risk of excessive bleeding.
Mm.
So let us talk about the pharmacokinetic interactions. We've spoken about pharmacodynamic already.
Yes.
Every drug goes through 4 processes: absorption into the body, distribution, metabolism, and excretion.
Mm.
Now, for absorption to take place, it has to go through the guts, and then there are 3 processes that can occur there in terms of interaction:
Okay.
changes in the GI pH, adsorption, chelation and complexation, and then changes in GI motility. Let me talk about adsorption, complexation, and chelation. My colleague mentioned antacids and antacids causing chelation.
Mm.
So, antacids contain calcium, magnesium, aluminium, and these are metals that, in the presence of drugs like tetracycline and fluoroquinolones, an example of fluoroquinolone is ciprofloxacin. When these drugs are taken together, they form insoluble complexes. For a drug to work, it needs to dissolve and go into the system. But in the presence of antacids, they form insoluble complexes. When they don't dissolve, they won't go into the system. When they don't go into the system, they won't work.
It will work.
So we need to keep about 2 to 3 hours interval between drugs like antacids and tetracyclines, drugs like antacids and fluoroquinolones.
Mm.
Now let's talk about the changes in GI pH. Usually, weakly acidic drugs are more absorbed in acidic environment. Weakly basic drugs are more absorbed in alkaline or basic environment. Now, when a patient, again, let's use antacid as another example,
Okay.
takes an antacid. Antacid basically is reducing the acidity of the stomach in patients that have ulcer.
Mm.
So when such a patient takes a drug like ketoconazole needs an acidic medium for absorption.
Mm.
When a patient takes ketoconazole and an antacid without adequate spacing, what you notice is that that acidic medium of the stomach becomes alkaline due to the antacid. Are you following?
Mm.
Due to the antacid. And then the ketoconazole that needs an acidic medium for absorption will not occur because the antacid has changed the pH of the stomach. So once again, we need about 2 to 3 hours spacing. Then let's talk about the changes in GI motility.
Okay.
The drugs are emptied, drug and food go through the stomach and emptied in the small intestine. A large amount of absorption takes place in the small intestine. Now, if there is a delay in that GI emptying, that emptying from the stomach into the small intestine,
Mm.
you notice a longer onset of action of the drug. Onset of action is basically the time it takes for the patient to start noticing relief.
Mm.
So if a patient is taking, say, opioids generally, for example, codeine, pethidine, they have that side effect of causing constipation. Constipation is delayed gastric emptying, basically. So you notice, for example, if the person is using codeine and paracetamol or pethidine and paracetamol, the person will notice that constipation, and that constipation will not allow the paracetamol get to the small intestine on time. So there will be a delayed onset of action of that paracetamol. That is another example. So we've spoken about absorption. I want to talk about another phase that the drug will go through,
Okay.
and that is distribution.
Distribution.
Yes.
Yes, please.
So for the distribution part, there are once the drug is absorbed,
Mm.
is now distributed to its site of action, and in the process of doing this, it may interact with other drugs. Now there are plasma proteins. Basically, these plasma proteins serve as a reservoir for drugs. Let's say a drug binds to the protein. There are two options. Either the drug is binding to the protein or the drug is free in the plasma. The drug has to be free in the plasma for us to see and feel the therapeutic effects.
Okay.
The more the drug is bound to the plasma, the less it is free.
Mm.
So now let us look at it this way. There are two drugs, and one drug has a higher affinity for plasma protein than the other.
Mm.
Let's take two drugs for example once again. There's torbutamide. Torbutamide is an anti-diabetic medication. And then there's sulfonamide. Let's take Septrin. Septrin is an example of a sulfonamide. So if a patient is taking both torbutamide and Septrin, what the patient would experience in this situation is that Septrin would displace torbutamide from the plasma protein. And then there will now be excess torbutamide free in the plasma. Now what we'll experience is that there will be excessive reduction in the blood sugar. You see. And then the patient is experiencing confusion, weakness, tiredness, and all that. That's another one. So let's go to the next stage, metabolism.
Metabolism.
Yes. Metabolism basically refers to the biochemical change of drugs, where after this, they are now free for excretion. Metabolism takes place in the skin, in the gut, in the kidney, but the major organ for this metabolism is the liver. Now there are two phases. There's phase 1, hydrolysis, oxidation, reduction, and phase 2, where they are combined with glucuronic acid, sulfuric acid. All these are pharmaceutical terms. I'll explain in simple terms.
Actually, you've got a lot of pharmaceutical terms. A lot of them.
Okay, so the liver contains enzymes, cytochrome P450 enzymes. Basically, now there are things we call inducers. Inducers are drugs that can increase the rate of metabolism faster than normal. Inhibitors are things that reduce the rate of metabolism. Now, when rate of metabolism is reduced, you notice an accumulation of that drug more than it should be. So there is increase of adverse effects and all that. So now let me quickly talk about induction. Let's take a drug rifampicin and oral contraceptive. When those drugs are combined, patients will usually notice a failure in the oral contraceptive, and then you hear things like, I was taking it, but I still got pregnant.
Exactly.
And that's because rifampicin is a strong inducer, such that it is increasing the metabolism of the oral contraceptive. So it's being removed from the body faster than normal. So yes, the patient is using it, but then they are mixing it with something else without giving that adequate space. Officially, when using rifampicin with oral contraceptive, there's supposed to be another form of contraception,
Okay.
because it has been shown that there's usually therapeutic failure when using rifampicin and oral contraceptive. That's because rifampicin is an inducer. So let me talk about the inhibition. We know amoxiclav, we know amoxil. Amoxil is basically amoxil itself, then amoxiclav is amoxicillin with clavulanic acid. Now, what's the rationale behind adding clavulanic acid? That's because clavulanic acid inhibits the enzyme that is to break down amoxil. Beta lactamase is the name of the enzyme. So it inhibits that enzyme. So what we notice is that there is a longer duration of action of the amoxil. So we've spoken about that. Let's talk about the last phase, that's the excretion.
Okay.
So these drugs are excreted in the kidney through changes in urinary pH, changes in renal blood flow, changes in active tubal excretion, and biliary excretion, and enterohepatic shunt. Now, once again, let me quickly talk about the pH. Weakly acidic drugs are more excreted in alkaline urine. So once again, in cases where there is, say, toxicity, you want to do the opposite. If the drug that is too much or the overdose is, say, acidic, you want to make the urine alkaline so that it's quickly excreted. If it's basic, you want to make the urine acidic so it's quickly excreted. Then when it comes to changes in renal blood flow, the blood flowing through, when there is reduced blood flow through the kidney, there is reduction in drug excretion through the kidney as well. So we want to advise patients who have one problem with the kidney or the other, maybe renal failure or whatever, whenever they are meeting their doctors for the first time, they should, or pharmacists to get maybe OTC medications, they should let them know so that they will take that into they'll factor it in. Then changes in biliary excretion. Our gut, that's like the entire stomach, small intestine, large intestine. We have normal bacteria there that are normal for us. They are not harmful, they are just normal. So
there could be bacteria that are normal.
Yes, they are normal and good for us.
Wow.
Like good for us. So this normal flora, they call them flora, this normal flora mix with the metabolites. You know, we've spoken about metabolism before.
Exactly.
They mix with the metabolites to change to the parent drug, and then they are reabsorbed into the body. That increases the duration the drug spends in the body. So in presence of, say, antibiotics now, this normal healthy bacteria is eroded. The antibiotic does not know whether this bacteria is good for her, is bad for her. It will clear everything. So in that situation, you see that gut flora mixing with the metabolites to give us the parent drug back that is reabsorbed, that process is removed. So once again, we want to advise that please don't use antibiotics indiscriminately, because even minus the resistance, there is that process that is gone.
I want to say thank you very, very much, Pharmacist Akaeze. That was quite very, very loaded, and I think I have learned one or two from that. Now let's look at this particular scenario where sometimes you hear of a person tell you that this is the drug I used, in curing a particular sickness or illness, and it worked for person A. Person B used the same drug that person A used, and is coming out with another reaction entirely or as a matter of fact, the illness might not even get going. It might even get worse. What happened in between there? What really went wrong?
I want to mention, like, remind us of what my colleague mentioned,
Okay.
resistance.
Okay.
We are not meant to just use drugs based on, oh, my neighbor, this is what Yalagbaja used, let
Mm.
me also use it. We are different. And once again, there is something called sensitivity test,
Okay.
where they run tests in the laboratory to tell which drug will work for which patient.
Mm.
So it's, yes, it's worked for that person. Doesn't mean it's
It will
worked
work
for
for
me. It's
you.
possible I'm already resistant to that drug.
Mm.
So the laboratory already does all the tests to tell us, use this particular one. Oh, this is what
Mm.
will work.
Mm.
So once again, just come to the hospital. Let them do all the tests for you and tell you which exact one will work, instead of doing trial and error,
Uh,
wasting money.
so that clears the air for people who will just say that because I've used it, you can also use it and it will be fine. And we have some set of people that will tell you that every time I go to the hospital, they will tell me to go through tests. Every time I go through tests, I did one last month, now I did one last 3 months. Why should I do another? Thank you for that clarification. I'm coming down to pharmacist Fagbenro, but I'll open the phone lines if there are questions at all to ask our pharmacist in the studio today. We are talking on drug interaction. Drug interaction is our focus today on the issues. We're looking at all of these conversations around drugs. Before I come down to you, Pharmacist Fagbenro, let's take this first call. Hello to you. Thank you for calling. Please go ahead, talk to us. Mm. Okay, unfortunately, we lost that call, but I think the summary to what our caller over there is saying is that first off, drug has become very, very expensive. But I want to believe that is not a pharmacist's fault. They are only here to clear the air on drug interaction, and at the same time, he's talking about the activities of the NDLEA, the National Drug Law Enforcement Agency, which of course is still not the duty of our guest in the studio to attempt to that one. Now, another question I would ask now, when you talk about drug usage, I'm coming to you, pharmacist Fagbenro. When we talk about drug usage, in some cases, you would hear a pharmacist or a medical practitioner tell you that you can use the drug anytime, before you eat, after you eat. Some will tell you use it before you. How does this really work? Is there a particular channel to which pharmacists such as yourself or medical practitioners dictate when you have to use a drug? You eat first or you don't eat. Don't eat it on empty stomach. Please, I need you to clear the air on that side because people sometimes get it confused. You see this particular drug, this person is saying I can use it without eating, and that person will tell you, my doctor said I must eat first before I use this drug. What is really going on?
Thank you for
Yes,
the
please.
question. Number one, my colleagues have mentioned something, just mentioned something now, under absorption.
Hmm.
There are some drugs, especially the one that has a heavy metal, as I've mentioned.
Hmm.
That antacid, for example, it has a aluminium, it has a magnesium, which are heavy metals. If that antacid is being co-administered or being taken with another drug,
Hmm.
definitely it's going to cause what is known as a chelation.
Hmm.
Chelation means that insoluble complex will be formed. For example, uh, uh, what's it called? Iron. Let's say from that antacid, for example, now, if antacid have the position of that heavy metal
Hmm.
on another drug,
Hmm.
is that chelation become insoluble, and if something become hard and insoluble, that means it's not going to be dissolved and absorbed in the system. Another example is iron supplement. Iron too is an heavy metal. If as the molecule is being deposited, the molecules of the iron is being deposited on quinolone, for example, ciprofloxacin, it's going to form an insoluble complex too. That insoluble complex means that the drug ciprofloxacin will not be able to dissolve, and once there is no dissolution, the drug will not be able to absorb in the system. So another one is for example, omeprazole.
Okay.
Omeprazole, because of that alteration in gastric pH, is under absorption too. Some drugs are weak acid, some are weak base. If omeprazole, for example, is going to be taken, they say that take it on empty stomach. And there's a lot of counseling that pharmacists also do, spacing, just because of that interaction. Take this 30 minutes before food, so that there will not be interaction, or take this an hour after food. Because immediately you take food and you take another drug, the one that is being taken can be affected by the presence of another drug that is in the system.
We still have a lot of questions to ask, and our time is fast spent. So let's talk about the consequences now. Is another very important thing to talk about. Tell us some of the consequences of drug interaction.
One, thank you.
Yes, please.
I told you that the goal of therapy is to have good therapeutic response. The patients will get well. So there are 3 key outcomes that is being expected from drug therapy.
Okay.
The first one is a
clinical outcome.
The clinical outcome means that the patients get well with the help of the drug that the physician prescribed. That's a example of a clinical outcome, good therapeutic response. The patient is well from the ailment that the patient is suffering from. Another outcome is a economic outcome. Patients that doesn't get well, we keep on visiting hospital. And visiting hospital every time, that means you'll be buying the drug regimen that is given this time, it has to be changed to another one because the drug doesn't work. So that means the patient will be losing much of money. And the useful time that patient supposed to go and for business, he be coming to hospital. Rather than going for his own daily bread, he comes to hospital every time. That means economic wise it's not favored this.
It's not even advisable.
What the last outcome that is being expected from therapy is humanistic outcome. Okay. Patient satisfaction. If patient comes to hospital and gets well, that's a good humanistic outcome.
There's this joy it gives to the medical practitioner.
And even the healthcare givers will be happy too. So, and other consequences, the major consequences from drug interaction, as my colleagues have said, is either drug causes, when the interaction occurs, is either it causes increase or decrease in therapeutic response. Second one is that it's either cause very rapid or slower action, while the third one is that it can cause adverse. Adverse usually means that it's an unwanted, unusual, no good response. So all these things will definitely take place if there's a drug interaction in place. So now, one of the major consequences is the 3 I've just mentioned. But at times, for example, he has mentioned the adverse effect that she rightly mentioned that when aspirin, for example, aspirin is a anti-platelet.
Okay.
It makes sure blood flow freely in the vein. While the other one that is warfarin is an anticoagulant. That one prevents clots forming in the blood, prevent blood clots in the vein. So these two, they have a similar action. But when the two are now co-administered together, it's going to have a excessive. It's like an enhancement. It's like additive or synergistic effect. So that means there can be bleeding. A patient on oral anticoagulants already, warfarin, and if a physician now prescribes aspirin, which is antiplatelet, the two, they have enhancement, the same so that there might be bleeding. And
let's take this call. Sorry to interject you there. Hello to you. Thank you for calling. Yes, thank you for calling. They are pharmacists, actually. They are pharmacists. Yes, please. Mm. Yes, please. Mm. 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 So they don't jam each other. Mm. Mm. Thank you very much. Your question will be attempted. Thank you, Mr. Yusuf from Alakuko. That question was still going to come in, but it's good a caller have already asked. And I apologize to those of you that have been calling and calling. We are not ignoring your calls. Okay, maybe I should start taking calls now. Hello, who's on the phone line? Okay, we lost that one. Pharmacist Akezi, maybe you quickly attempt that question. It was directly thrown to you, and you have to do justice to it in just 1 minute.
Okay, thank you, Uncle Steve, for that question. There are medications that are more likely than others for interaction, and these are medications that have a narrow therapeutic index. Narrow therapeutic index basically means that any that you can't there is a narrow range over out of which toxicity begins. An example is digoxin. Digoxin is for the heart, and if you go over that narrow range, then you begin to deal with overdose and toxicity. Others include theophylline for taking care of asthma, then carbamazepine and other anti-epileptics, phenytoin and co are other drugs too that are more likely than others to for drug interaction.
Okay, I want to ask you this very, very. It might sound funny, but I want to believe that it should help us, some listeners. When we say drug abuse, many people would believe that it is the consumption of hard drugs. But some of those drugs that we take to cure some of our illnesses could also, be equivalent to saying drug abuse. So let me ask this simple question. I don't know who is going to answer among the two of you. What is drug abuse? When do we start abusing drugs? When can you, as a pharmacist, say a client has abused drugs?
Thank you.
Yes, please.
Drug abuse can start from taking drug without consulting the physician or pass through the pharmacist for for proper counseling and nutrition. So if one self-medicate
Mm.
today, the drug works, the patient go back to get to buy that drug again.
Mm.
All of as he's taking it second time, third time, I mean the patient is abusing the drug.
That is drug abuse.
Yeah. So one must be very careful.
Mm.
First self medication, so to some extent. So and to avoid taking what's it called the same drug over time.
Mm.
You have to follow follow what's it called proper counseling
Mm.
from a pharmacist.
It's unfortunate that we have to go, and I want to sincerely apologize to those of you that are still currently calling. I can no longer take in calls. Our time is fast spent. I don't know if our pharmacist in the studio would grant us another opportunity, to join us again, because we did not even talk about the management of a drug interaction.
And actually, the risk factors that we
Mm.
mentioned. Now, to now manage it,
Mm.
there are some kits.
Can we do that in just 1 minute? Our time is fast spent. We have to go
Okay,
down
okay.
to another.
Okay, thank
program.
you. Now, first, number one,
Mm.
the risk factor have to be identified. Just
Okay.
as I explained the other time,
Mm.
that a physician will identify whether patient is comorbidity,
Mm.
a patient is it has plenty drugs,
Mm.
polypharmacy. So those are the ways to attack. Once you are attacking the risk factor,
Mm.
then you are managing it. First of all, number one, identify the patient risk factor.
Okay.
If a patient now is taking aspirin, the
Mm.
patient is on anticoagulant like for example, and the person is having pain,
Mm.
instead of prescribing aspirin,
Mm.
which have the same pharmacology action with warfarin,
Mm.
you prescribe paracetamol instead. So that means the patient that's having a risk factor for drug interaction between the two, the physician have settled it by prescribing paracetamol. Now, the second is that taking thorough drug history.
Mm.
From the history, that's why I mentioned that past and present medication history.
Mm.
Past and present medication history, we reveal that this person is a non-compliant patient, which is a risk factor. We show that the person is suffering from many ailments, multiple ailments, multiple therapy. All those things are risk factor. So another thing is that avoid complex therapeutic regimen. That is polypharmacy. That's another way to treat, to manage drug interaction.
We have to go, unfortunately, but definitely you're still coming back. I want to thank you very much, pharmacist Akeze, and of course, I thank you to pharmacist Fagbenru. We're leaving the studio already, and of course, there's going to be another time for this conversation. Health is wealth, and that is why we have this conversation on the issues. It's a bye for now.